So thyroid tumors usually present as a solitary nodule. And these thyroid nodules, if you see a thyroid nodule though, it's more likely to be benign than malignant. But if you have a tumor, it's going to present as a solitary nodule. So the way you differentiate a benign versus a malignant nodule is you do something called an iodine radioactive uptake study. And what happens is you can have a nodule from things like Graves' disease or from the multifocal nodular goiter. And these nodules would have increased production of thyroid hormone. So when you give this iodine, this is radioactive iodine, or is this, you can trace it because it's radioactive markers. When you give this iodine, you're going to see that this nodule is going to have increased uptake of the iodine because it's using that iodine, it's uptaking the iodine to make more thyroid hormone. And we call this a hot nodule. So if you see a hot nodule, it's more characteristic of something like Graves or a nodular goiter. These are benign thyroid nodules. Now if you see decreased uptake of iodine, so something called a cold nodule, this indicates you have non-functioning tissue, and this is characteristic of a thyroid adenoma or carcinoma. So hot nodule, what do we say that was? That was either Graves or a nodular goiter. These are thyroid nodules that are benign. And if you have a cold nodule, that means decreased uptake because you have non-functioning tissue. That's either an adenoma or a cancer or a carcinoma. Now I want to emphasize that a thyroid adenoma usually does not secrete thyroid hormone. I want to emphasize that because in the rest of the endocrine system, you see that adenomas do have increased hormone secretion. You saw the pituitary adenomas, adrenal adenomas, parathyroid hyperplasia, all of that can secrete extra hormone, but thyroid adenoma is cold. It does not. It's decreased uptake. It's a cold nodule. Now, sometimes though, even this uptake study doesn't do enough, and you may need to do a fine needle aspiration to differentiate between, let's erase this so you can see, between a benign nodule and thyroid cancer. Okay, this fine needle aspiration, you stick it into the nodule, you aspirate some cells, and you can see if you have malignant cells or not. Finally, our thyroid cancer can develop from both thyroid follicular cells, these are also called thyrocytes, or from parafollicular C cells. So this is a picture here. This is one follicle, and honestly, I'm just going to draw it for you. So this is our follicle. You see they're around the lumen. These are the thyroid follicular cells, okay? These are the thyrocytes. And then you have some other cells around the follicle, but not in the follicle. These are parafollicular cells. These are the C cells. You can get tumor from the C cells, and you can get tumor from the thyrocytes. So let's talk about the type of tumors we can get from the thyroid gland. So we talked about, so these are the thyrocytes. Remember, you have thyrocytes and parafollicular cells. So tumors from thyrocytes include papillary thyroid carcinoma, follicular thyroid carcinoma, and anaplastic thyroid carcinoma. Okay? So these are the three that come from thyrocytes. We also have stuff that comes from the parafollicular cells as well. Now we're going to talk about differentiation as well. So these two, the first two, papillary and follicular thyroid carcinoma, are well differentiated. And what does that mean for our prognosis? Remember, well differentiated means good prognosis. And on the other hand, anaplastic carcinoma is poorly differentiated, which indicates poor prognosis. Now we're going to focus on papillary thyroid carcinoma now. And the features here are, you're going to see orphan Annie cells. These are empty. These are orphan Annie eyes. These are empty appearing nuclei. You're going to see this right here. This is orphan Annie. These are her eyes. You see they're completely empty. And these are your cells. There's no nucleus, so they look completely empty. They look like orphan Annie eyes. Next, you're going to see psammoma bodies. So, remember, this is the one that has like all the layers. And do you remember what I told you about psammoma bodies? There's a nice mnemonic because there's multiple tumors that make psammoma bodies. Remember that our mnemonic here was, I'm going to write it here, psammoma. And what does that P stand for? Well, P stands for this, papillary thyroid carcinoma. What does the S stand for? This is serous cystadenoma, cystadenocarbcinoma of the ovary. And then the two M's. One is meningioma, one is mesothelioma. That's the malignancy of the lung pleura. So these are all all tumors that can have psammoma bodies. Papillary carcinoma of the thyroid, serous cystadenoma of the ovary, and the meningioma and mesothelioma. And finally, you can see nuclear grooves. These are all features on histology of a papillary thyroid carcinoma. There's also a few associations that you want to take note of. These are lower yield, but if you want to have all your bases covered, you can just memorize this. RET, PTC rearrangements, BRAF mutations, childhood, radiation, all risk factors for papillary thyroid carcinoma. Now, if we go to follicular thyroid carcinoma, what you see here is you have uniform follicles that invade the thyroid capsule and the vasculature. And it's this invasion of the thyroid capsule that helps you distinguish this follicular thyroid carcinoma from follicular adenoma. And a follicular adenoma, in contrast, is a benign proliferation of thyroid follicles, and it's surrounded by a fibrous capsule. Okay, so in a follicular adenoma, there's no invasion of the thyroid capsule. In the carcinoma, there is. Now, remember we talked about how do we differentiate between benign and cancerous and tumors? When we said we use the fine needle aspiration. Unfortunately, fine needle aspiration doesn't look at the capsule, it just aspirates cells. So fine needle aspiration can't help you distinguish between a follicular thyroid carcinoma and a follicular adenoma. Okay, you need a complete biopsy of this stuff. You need biopsy to include the capsule to be able to see whether there is thyroid capsule invasion, which would tell you it's follicular thyroid carcinoma. Now, the other thing to know about this is there's hematogenous metastasis. Okay, remember that usually our epithelial cancers metastasize lymphatically. Remember, there were a few exceptions to this. What were they? Remember, there was renal carcinoma, liver carcinoma, and then you have this follicular thyroid carcinoma with hematogenous metastasis. And remember, sarcomas also do this, but sarcomas are not epithelial carcinomas. Alright, and then the association you want to know follicular thyroid carcinoma is a RAS mutation. You also have this one, but the key one to know is the RAS mutation. Alright, finally we go to the anaplastic thyroid carcinoma, poorly differentiated. I just flashed that for you, but I already mentioned this before, and I already told you about this. How does this present? Remember, this presents with invasion of local structures, and this can lead to dysphagia or respiratory compromise. Remember, I told you about this because I told you about rhinofibrosing thyroiditis, which can also have fibrosis of surrounding structures. But this one, in anaplastic carcinoma, you see this in older patients. Okay, and finally, we go to the tumors of the parafollicular C cells, and this one will be the medullary carcinoma. Now, medullary carcinoma is also poorly differentiated, which is why we have this chart organized in this fashion. We have the top is all the thyrocyte tumors, and then we can see that the first two are well differentiated, the last two are poorly differentiated. Now, this medullary carcinoma, what hormone would it make? What hormone does parafollicular C cells make? I told you about this earlier in the parathyroid lecture as a hint. Remember, this makes calcitonin. What does calcitonin do to calcium levels? Remember, calcitonin will decrease serum calcium levels. Remember, we call this calcibonin, so calcium stays in the bone and does not go into the serum. So you have lower serum calcium levels. And what you're going to see here is if you biopsy it, you get sheets of malignant cells and amyloid stroma. And remember, amyloid, how does amyloid stain? You see this over and over again. Amyloid stained with Congo red. So this is very high yield. You get malignant cells and amyloid stroma in a thyroid tumor. You know it's a medullary carcinoma of the thyroid. And the association here is RET mutations. And this is in the MEN syndromes, MEN2A and MEN2B syndromes. We're going to talk about these syndromes in a little bit. But both of these syndromes have medullary carcinoma of the thyroid, and the syndromes have pheochromocytoma, so they're multiple tumors. MEN2A also has a parathyroid adenoma. MEN2B has mucosal neuromas of the oral and GI tract. Okay, so that is it for our tumors. The treatment here will be surgery. Just see the Graves' disease treatment lecture, the one that came previously for surgery side effects. If you just watched it, we can actually review that really quickly. What were the side effects of thyroid surgery, of removal of the thyroid? Right, side effects include permanent hypothyroidism. You're taking out the thyroid, or you can also damage the parathyroid glands. And parathyroid glands sit on top of the thyroid, so you can get resultant hypocalcemia. Remember, the nerve that you can damage is the recurrent laryngeal nerve, and the symptom you would get here would be hoarseness. Okay, so that is it for our thyroid tumor review. Again, we have papillary thyroid carcinomas. The key here, you have histological features, very characteristic, very key. Orphan any cells, nuclear grooves, Simoma bodies. Follicular thyroid carcinoma is invasion of the thyroid capsule. Remember that fine needle aspiration does not help you differentiate this from thyroid adenoma. Anaplastic thyroid carcinoma, very poor prognosis, invades local structures. Medullary carcinoma with the amyloid makes calcitonin because it's from parafollicular C cells and not from thyrocytes, and it's associated with the MEN syndromes. So that's it for our thyroid tumors.